Well, the problem with the osteoporosis medications is that they're given to the patient to prevent fractures. That's the goal. The problem is that trials have shown that that goal is really not reached. And then in the process, you also get pretty bad side effects and long-term side effects. And so it's kind of like, it's almost like, and I know I keep going back to the hypertension and to the cholesterol medications, which we think that if my cholesterol is a better number, I'm not going to get heart attacks. But the problem is with those medications, just like with the osteoporosis medications, is that that goal is really not reached. So people just feel safer because they're on those meds, but in reality, they're not safe. Every medication causes a deficiency in some kind of nutrient that's important all the way down to biochemistry.
Welcome. Today's guest speaker is Mihaela Gruita, who is a pharmacist, spent half of her career in a clinical setting in a hospital, the other part of her career in research, and she now calls herself a naturopathic pharmacist. She reaches for natural remedies first to manage symptoms before reaching for medications. So my population is going to be women with osteoporosis that are trying all that they can naturally without going on medication. Most of them are avoiding medication, don't want to take. So I would like to educate them also on what are the medications they're taking and what are they doing? Because if someone has osteoporosis, let's look at what are the root causes of osteoporosis. And when you look for root causes, quite often you'll see medications can be a root cause of osteoporosis. So I would like to discuss the whole aspect of how medications contribute to mineral deficiencies and what have you noticed in your experience. Explain a little bit more about that.
Sure. Many medications affect our nutrient status in different ways. So, for example, the first medication that I would tackle is something like the medications for acid reflux, because if you talk to people, pretty much every other person is on something of that sort. And what's even more scary is that they're on it long term. Even the drug company has a black box warning on them saying that if you do use it long term, you're going to get osteoporosis, you're going to break bones. So even they're saying that, but we know, we've known this. So, and when you do have the backup of the pharmaceutical company telling you that that's what will happen to you if you take it long term, it's kind of, you have to open your ears and eyes and do something about it. So, so the way it does it, it changes the acidity level in the stomach, and so digestion though is dependent on that acidity. So so you hear people say you are what you eat. Well, you are what you digest and what you absorb. And so you could have the most pristine diet, but if you do not have the right acidity in the stomach, you're not going to be able to cleave off the minerals, the vitamins, the amino acids from a piece of steak, or the fatty acids from your avocado you just ate. If you didn't break down the protein down to an amino acid, you're not going to absorb any of the amino acids because you don't have the amino acids. You didn't break it down to that. And our body is designed in such a way that you can only absorb amino acids. If the protein is only cleaved down to a peptide, which means more than one amino acid kind of together, the body in theory should not be able to absorb that unless you have leaky gut. And then if you have leaky gut, your immune system will attack it because it will say, well, I don't know who you are, you must be foreign, I'm attacking you, and that's how you get autoimmune disease. So I guess this was like digressing a little bit. This is even more advanced, but even down to the fact that you're not digesting things, you could be having a full belly, but you are going to be malnourished. You're not going to have the nutrients. And if you don't have the nutrients, all health will be influenced. So, but especially bones, because you do need calcium, you need magnesium, you need vitamin D, you need vitamin K2. So if you don't have one of these ingredients, bones are going to suffer because the body will actually take from the bones what it needs. So
Right.
if you
Yeah.
don't have enough calcium, the body will say, oh, let me get it from the bones or from the teeth. For a while, you're going to have calcium, but it will be at a big cost. So,
Yeah, so interesting. So I run a lot of functional labs on my clients, and during the intake process, I'm amazed at how many women have gut issues and how many of them are on different medications. So some of them, the famotidine is the one that I've been hearing about a lot recently. And then others have been on PPIs or they were on the PPIs, the protein pump inhibitors, which are going
mm-hmm,
to stop digestion. The protein pump inhibitor is actually stopping the digestive enzyme that breaks down protein, that brings it into these smallest building blocks possible, the amino acids, which are going to build bones. So it's really, really amazing. And a lot of women don't actually understand that. They don't understand how strongly correlated gut health is or digestive health is to bone health. Because on
mm-hmm,
one hand, not only do you not bring in the nutrients, if they're not, so either you're not bringing them in, which is a deficit, but then on another deficit, if you don't have enough nutrients in your body, when your body needs calcium or magnesium or other minerals to manage inflammation or any other processes that are going on, it's going to dissolve your bones in order to free up the minerals it was storing into the system. So it's
mm-hmm,
really imperative that people, like you said, it's not about what you eat, it's about what you digest and absorb and assimilate into your body.
mm-hmm.
So yeah, that's really so what are the common drugs that would be given for digestive disorders?
Yeah, so famotidine, as you said, that's common. It's not as strong as the PPIs. So more often than not, I see patients on PPIs. So those are the pantoprazole, omeprazole.
Omeprazole, yeah.
Uh-huh. Those are and majority of them, scary enough, they're over the counter. So I think the misconception out there is that drugs that are over the counter, they are safe. And there's absolutely no, so for the longest time, these PPIs were just on prescription. And then I think it was shortly after I graduated from pharmacy school, they put them over the counter. They didn't change the dose. They didn't, I mean, it was just the same drug over the counter. And people think they're safe. No, they're not safe. People don't know anything about these medications. They just think, oh, it's over the counter. I can either reach for a gallon of milk or I can reach for my omeprazole. That must be safe as milk. Although we can even go into that
We could go
conversation,
into
but
dairy.
right.
Okay,
So,
that's so interesting you're saying this because I have one client and I remember her telling me that actually a few of them, when they talk about being on famotidine, is that how you say it? Famotidine?
mhm,
When they talk
yeah,
about being on it, they talk about it as if it is not a PPI. So it's almost like there might even
it's
be an
not.
awareness for some people as a PPI, yet it still has
Yeah.
does it still have a neutralizing effect of stomach acid? Is it going to still, does it
It's
alkalize
the
stomach acid?
right,
Yeah.
right,
So it's still,
and
yeah.
yeah. So if you don't have the right acids, because the acid itself will be cleaving off big the big food into smaller parts, right? And then that pH or the acidity in the stomach will be triggering the gallbladder to release the bile to complete digestion, and then other pancreatic enzymes will also come into the small intestine and then finish off the digestion. Well, those things will not even know to come in there because the pH is not where it needs to be. The pH is a measure of the acidity. So we should have the acidity should be at about 1.2. The pH should be 1.2, which is the same acidity as the battery in the car. So it's very acidic. You put your finger in there, you'll figure out how acidic that is. But it's really acidic. And
Okay, so
when
wait, when it comes into the small intestines, it needs to be at the 1.2 acid
Mhm.
level in order for, is it elastase 1, some of the pancreatic enzymes that are coming into the stomach,
Right,
into the small intestines? Because we find
Right.
that
And
in a
even,
GI map. When we run a stool lab,
yeah,
we find
yeah,
the levels of pancreatic enzymes in stool.
yeah.
So it
And
comes
the
into the
bile.
okay, so it comes into the intestines, and when it's in the intestines waiting to be further digested and broken down, is the word cleaved similar to broken down, breaking down?
Yeah,
Okay.
yeah.
So when it comes from stomach into small intestines, there needs to be the proper pH in order to stimulate either pancreas to stimulate the pancreatic or the elastase 1s or the pancreatic enzymes, and for the gallbladder to release bile, which is what
Mhm.
mycelates or breaks down fats, which
Correct.
vitamin D and vitamin K are imperative to bone health. And so we need that digestion of those fat soluble vitamins in order.
Hmm.
So this is interesting. So not only do you need you need the stomach to be able to digest and to be acidic, because then the next layer down, it's going to be stimulating the digestive elements of bile and enzymes. And then it needs to be broken down enough, going back to what you said earlier about being in the right form in order for the body to utilize it into the amino acids versus
Yes.
being still, partnered up or whatever the correct term is. Yeah, that is so interesting. So there's multiple layers to the PPIs. Now,
Oh.
the burning that someone feels in their stomach or in their esophagus or the lump in their throat, this is because the acid from the stomach, usually if they're not digesting properly, it's almost like it's coming back into the esophagus.
That's pretty much it. People are under the impression that, oh, my stomach is too acidic. That's why I'm feeling this burning up the throat. But it's not that. It's the fact that things are not moving along because digestion is impaired. And so where are they going to go? The only way to go is the way up. And so then if that sphincter in the esophagus is also not malfunctioning, then things are going to come up your throat and it will burn and it will be super painful. The pain will go away because if you lower the acidity, then that thing is just not as acidic, so it won't hurt. But that doesn't mean it's not happening, and it doesn't mean that you now are digesting it. It's in fact you're making it worse and you're really not digesting. And um, so yeah, because many times as we get older, the acidity will suffer for various reasons. So instead of actual, and interestingly, if you try to cure this, if you give somebody more acid, then they're not gonna, the digestion will happen, things will move down, and they're gonna have less acid reflux. So it's like counterintuitive, but that's how it happens. So
Wait. So
so
are PPIs acidic? Are the medications, are they acidic?
no, they're
No.
not
Okay.
acidic themselves, but they're gonna prevent acid from being released in the stomach.
Right.
Because when we eat, so the stomach will always be acidic to some extent, but then when we smell or mentally we're preparing for food, um, more acid will be released in the stomach in preparation for that food coming in and in preparation for digestion. So these medications like famotidine, that's an H2 blocker, and pantoprazole is a PPI. So both these drugs will prevent um, acid being released into the stomach. And so if that happens, then you're just not going to be able to digest properly, if at all, and depending on how bad the the stomach acid is. Like, so if it's really alkaline, then digestion can be worse than for other people. So there's different levels. It's not like everybody will be this bad or
Right.
this
Right.
good, right? So
Yeah. And
so there's everything in between.
we see
So
that in stool labs. So when you run a stool lab, some of the intestinal markers you get an elastase 1 marker, you get a steatocrit, which is a fat marker to see if you're metabolizing fat, to see if you have sufficient pancreatic enzyme secretion. And now you've really enlightened me on the aspect of the pH that's necessary for these functions to take place. So that's really interesting because it's all about balance, and it's this whole system is reacting according to different balance or whatever it needs. And in this case, that acidity is 1.2, the number of acidity that's necessary for bile
So that's
secretion.
the yeah,
Yeah.
that's the pH. In chemistry, that's how you measure acidity. It's called the
Mhm.
pH.
Yeah.
So you might hear people telling you, "Oh, and another level is like there are people that just heard that if they have alkaline water, that's really good for them. Well, not if you do that when you eat, because it's the same as taking a PPI.
Yes.
You just put a chemical reaction. You just neutralize the stomach acid. So
Yeah, I
you know,
take people
so
off of
the
that
biggest
hydrogen.
mis
I mean,
yeah, and that's the biggest mistake. It's like there might be a place for it if you're on an empty stomach. That basically means you shouldn't be eating about a couple of hours after you had that water. Um, but if you drink that water in the same time when you eat, is the same as taking a PPI or H2 blocker, and that's a problem. And so, that's the thing. Like, there's so many things out there that claim that they're good things, but they're not good things.
they're
And
not good
so,
things. They're not good for bone health. I mean, because that's my world that I'm in. They're
right.
not good for bone health. They're not good. And so then we can learn certain behaviors around food. You mentioned the secretion before for eating, so really preparing for meals. Just like we
Mhm.
salivate when we see a lemon, right? Because that's amylase that's being which is what breaks down carbohydrates in the mouth. So that's going to be we can feel that in our mouth. We don't necessarily feel that our stomach is secreting digestive enzymes, but it is. So really preparing for food. Okay,
Yes.
so let's then discuss. That's really interesting because that is something that a lot of the ladies I work with are on. And is one of them called Pepsid? Is Pepsid
Mhm.
something? Yeah, is that one of the over counters that used to be prescribed? Yeah, because
Yeah.
when they tell me some of the ones they're taking, it's almost like, oh, but it's not a PPI. But now you're really shedding light that it's really none of them are good. So then it becomes, let's get
Yeah.
to the root causes of why you're not digesting. So supporting digestion, whether that's through digestive enzymes. And then with digestive enzymes, you have to be careful because if you do run a stool lab and someone has H. pylori, which I think there's an NIH study that says 25% of the people, women with osteoporosis, have H. pylori. So and I find it a lot in the labs that I run. If you have H. pylori, you can't use HCl, so then you have to choose different digestive enzymes. So the whole thing about I think that women are frustrated because they're really trying to do the best that they can do, right? They're trying to learn. They're like, should I take this, should I take this, should I take this, should I take this? And when people come to me to work with me, it's like crazy how many supplements they're on. And then I have to
Mhm.
inform them your liver and kidneys have to manage all of these supplements. So really important for us to support digestion and not with medications because they might be a band-aid solution, a temporary solution, but they're really actually going to affect what you're bringing in as building blocks of tissue. Okay, so one of the things that I love that you shared with me, and I'd love for you to share with my audience, is this. I call them the four musketeers of bone health, right? There's four main nutrients we need. And you and I had this discussion, and you really put it into perspective for me how they work together, what their relationship is. So can you talk and share that, please, when you share that information with us?
Sure. Yes. So everybody knows that you need calcium. If you don't have calcium, your bones are going to be weak, your teeth are going to be weak. And so there's a big push out there like, get your calcium, drink your milk that has calcium. And if you go to the doctor and you have osteoporosis, that's the first thing they'll put you on calcium. And unfortunately, they also forget to talk about the fact that there's calcifications in the arteries, and that oftentimes turns into heart attacks. So also there's calcifications in breast tissue, and that is precancerous. So clearly, calcium, unless it's where it needs to be, it's not necessarily a good thing. Do we not need any calcium? No, that I'm not saying that. Muscle will not move without calcium. So yeah, we do need calcium everywhere. we just don't need as much as we think we do. And in addition to that, if you don't have magnesium to go with it, you first of all that calcium will precipitate. So it goes back to chemistry 101, really. It's calcium will go into solution up to a certain extent, but then when you put magnesium, it will finish the dissolution. So we will you'll have a liquid with no solid in it, right? But if you don't have enough magnesium, that calcium will eventually precipitate, and that's most likely how we end up with calcium in the soft tissue, like the arteries, the breast, as I just mentioned. So calcium.
Okay, wait. Your visual was really great about this to me because you kind of because I try to visualize that. I love visualization. You said it's like boba, right? Is this when it's like boba?
Right. So it's like if yeah.
So you see these little. So for
like
people
if you
who
stir.
yeah, if people don't know what boba is, it's the tea, and at the bottom are these balls, these jelly balls.
Mm-hmm.
And so you're saying that the calcium needs to actually be almost like dissolved and turned in it so that you don't see it anymore, right? If the boba you would see. So it has to be dissolved in order for it to be picked up and delivered to the bones.
Right. So if you want to think about boba, if you were to stir the glass with boba, if you do it fast enough, you couldn't distinguish anymore the liquid from the boba balls, right? But when you stop stirring, the boba will basically go to the bottom, liquid to the top, and you'll have two different layers, right? Distinct layers. So that's how calcium will dissolve, though, a little more into more than the boba will in the tea, right? But if there is not enough magnesium, it will only do it up to a point and the rest will precipitate. So it's kind of like when you put sugar in the water, but you put too much sugar, it will dissolve, but some of it then will go to the bottom. So, and then you put the magnesium and you will finish the dissolution. And now you're going to have a clear liquid. And all this, just in our minds, just to realize all this should happen in the blood. And then you need vitamin D to actually do the absorption. If you don't have vitamin D, you cannot absorb the calcium. And then, so you need vitamin D, absorb the calcium. You need magnesium to make sure that keeps the calcium dissolved so it doesn't precipitate. And then vitamin K2 will pretty much take the calcium by the hand. I know you love that expression. And then put it where it needs to go, in the bones or in the teeth. And if you don't have enough vitamin K2, that calcium can go wherever. And then if you're also low in magnesium, it will precipitate. And that's how you end up with calcium in the arteries, in the breast tissue. And you don't want to have either one of them because you don't want a heart attack and you don't want cancer, breast cancer. So it's very important for us to make sure that we eat food that's rich in all these 4 nutrients. And if we are deficient, we need to supplement, but then figure out, well, why are we deficient? Do we not have stomach acid? Do we just eat terrible food? What is it, right? So
yeah, and then we've spoken about part of what makes the mineral deficiencies are medications.
Yeah.
Right.
Yeah. So and there's various mechanisms, and one of them being the stomach acid, as we just discussed. But other times, the medication might inhibit an enzyme from taking or carrying the nutrient to the cells where it needs to go. So you might have a nutrient in the blood, but not in the intracellularly where it needs to do things. Or so there's various methods by which the nutrients will be depleted. But a lot of the medications, like hypertension medication, diabetes medication, will deplete things like magnesium. And we just talked about the importance of magnesium. It will deplete calcium. It will deplete many other, including vitamin D and vitamin K. So you got those depleted. Here you go. You just don't have calcium in the bones, and then you're going to have bone disease. So
So are some of the medications, like I have some clients that are on statins,
mhm.
that's going to have an effect on magnesium absorption?
The statins, yeah, I believe so. That it will deplete magnesium, but it will. The statins are in a league of their own, but they will deplete a lot of things, and more than anything, they will deplete the coenzyme Q10, which basically will destroy the energy production inside our cells. And so the way I look at those drugs is that if your weak link is in the bones, and now you also deplete those cells, the bone cells of their energy, you're going to have even more disease. So that that's where they're a big problem with the energy production. And I'm not entirely sure. I would have to refresh my memory on whether they deplete calcium, but and magnesium. But again, even just by virtue of depleting the energy, you just have a problem on your hands. So
Yeah, it's not just about having energy and being in fatigue, right? That's one thing that I try
mhm.
to explain to people. It's not just about, are you tired? Do you have energy? Do your
Yeah.
cells have energy to build more bones, to build more skin, to build teeth, to build
Mhm.
muscles? So we
Yeah.
have to have this internal energy in order to
Yeah.
build ourselves.
Yeah.
So we have to, so it's this whole system. And
Right.
that's why it's not just a piecemeal approach. It's not just
Yeah.
take vitamin D, take calcium. um, we kind of spoke a little bit. I know that this is us more from a holistic perspective when we talk about dairy. And we talk about like what that, because that's where a lot of women believe that they're getting their calcium from. And, there's 7 root causes of osteoporosis, inflammation being up there, stress being up there. We have mineral deficiencies, which we've spoken about, toxicity, which we've kind of a little bit talked about, that acidity, which has to do with the pH balance. So that's going to be there. And then I think I said mineral imbalances, hormone imbalances, acidity, toxicity, stress, inflammation, and then being sedentary or not creating that mechanical stimulation on a daily basis. So when it comes to women thinking that they need to eat their dairy to get their calcium, that's probably one of the biggest shocks for people when they first start working with me is no dairy. No
Mhm.
dairy. It's highly inflammatory.
Mhm.
And so thoughts on that?
Yeah. Um, Nothing in particular, but yeah, I agree. It is very inflammatory. It's highly allergenic too. And so it can cause food sensitivities further than, and then it's also the proteins in the dairy are very similar, up to 80% or so similar to gluten, types of gluten. So even just by virtue of that, the immune system could mistaken it. So after a while, the immune system is so revved up if you keep eating the wrong things that they don't just take a little pistol and they're looking at the target. They'll just take a shotgun and just basically kill everything in place, including the dairy protein. And so you just create a big mess in the body. That's how you get a lot of inflammation from the dairy. And
Yeah, and
so
that is the
yeah.
biggest thing. That is really the biggest thing. And so that's what I say. They say, "Oh, I'm not sensitive," or um, you know, but really it's about the inflammatory aspect. I do run a serum food sensitivity lab, and when we look at dairy, we look at all the different immunoglobulins in the profile. There's a couple in particular. There's 2 proteins in dairy that we look at. One of them actually mimics the islet cells of the pancreas, so the insulin producing cells. And so if your body, like you said, the immune system, in order to conserve energy, it doesn't just attack that specific protein. It's whatever's in the vicinity of it, right? So
Yeah.
the islet cells can overlap with one of the markers in dairy, and then also neurological. So some brain aspects can be overlay there as well. So yeah, that's
Mhm.
really, I think that you've spoken so much about balance and starting off with learning in chemistry how the body maintains balance. Everything, the goal is homeostasis. And so everything is about maintaining balance, and even what we're talking about here. And with bones are, it's a remodeling process. It's a metabolic process. And I like to say the bones are either building or dissolving. They're either building themselves up with the minerals. You shared with us that you need the vitamin D to absorb the calcium. You need the magnesium to put the calcium in the solution for the bones to be able to absorb it. You need vitamin K to take it by the hand and take it to the bones. There's also some other minerals. I believe that boron and maybe even manganese has some of those. I don't know if it's cross talking or what the correct terminology is. Um, and so, and then all of that. So you need everything to be in balance. But yes, it's building or dissolving. And
Mhm.
so, all trying to find that balance in your body, making sure you digest. And when it comes to medications, it's really important because we've kind of it's been the way we've been trained. The I don't know when medications really started taking off. Was it like the 80s or the 90s or the 70s where we started to really develop medications?
I think in the last 100 years or so, we like FDA, for example, was formed in 1930s, 1936, I think, somewhere around there. But there were medications on the market before that. And so what happened, they never went through clinical trials. And there's a very famous over-the-counter medication that's in that category, and that's aspirin. Aspirin has never been through clinical trials. It was grandfathered in when FDA was formed, and they just said, "Oh, we've been using it for all these years." And I think most likely at that point they were thinking, plus we don't have anything else, so we might as well just grandfathered it in. Now there were laws where the drug companies were required to go ahead and do clinical trials on effectiveness and safety. But who do you think was going to do clinical trials on aspirin when an aspirin is 80 cents? So there's no money to be made, and so there's no clinical trials. And yet, um, there's a number of drugs that make the top 10 medications that will land you in a emergency room, and aspirin is number 3.
Oh, wow.
So Tylenol is number, I think it's 6 or so, and the ibuprofen is number 7. So people really think that these medications are safe, and they're not safe at all. And
Yeah, they're
top
not
10
safe and they're
causes of going to ER.
yeah, and they're terrible for your gut. I know. So when I used to play tennis and I would actually take 600 milligrams of ibuprofen prophylactically, either before I
Yeah.
played or even after if I was in
Yeah.
pain, not even thinking about it. And now that I understand what it does to your gut, to that balance in your gut,
Yeah.
I think honestly, last year I took Advil. I'm not kidding. I took it twice in the whole entire 365 days.
Yeah.
And now I will reach for minerals to get rid of a headache. If I have a headache, I'll either use caffeine because so many medications contain caffeine, right? It's a
Mhm.
vasodilator. So many medications contain caffeine, or I'll get a glass of water and some minerals, thinking maybe this is a mineral imbalance. And it's really amazing because quite often it works. Or I'll do deep breaths and I'll try to oxygenate my body. Um, because one thing I'd love for you to say, and if you have time to speak about this, is that what another thing that's really intriguing to me is the kidneys. And so when the kidneys are the filtration system, right? And if there's metabolic acidosis, if you're too acidic, the bones are going to dissolve to release alkalizing minerals for the kidneys. And then some of these osteoporosis medications, how they gauge when you have to stop taking them is when they notice there's dysfunction in the kidneys, right? That's some of the markers. Like they either look at liver and kidney enzyme markers to say, uh-oh, maybe 2 years is enough for this because after 2 years, these started happening. So, can you shed light a little bit on maybe some of the medications that are more common and how they're affecting kidneys, and especially as that relates to the bones dissolving to release those alkalizing minerals to manage that?
I think that's a big topic. Um, so
Figures.
a lot of medications will affect the kidney function. In fact, one of the jobs of a pharmacist in the hospital and more in the hospital, the outpatient pharmacists don't really have access to the labs, but in the hospital you have the labs. And one of the things we were always looking for is, okay, here's the renal function and here is the new prescription. Is that prescription appropriate? Do we need to change the dose based on the renal function? So what happens when if you don't have good renal function, you're gonna accumulate the medication that's supposed to be eliminated through the kidney. And when you accumulate it, then you're gonna have side effects, more pronounced side effects. And on occasion, you are also going to further damage the kidney. So when you don't have the kidney properly working, then you're gonna have toxicity. So because that's the job of a kidney and liver to eliminate toxins. Um, so clearly medications and kidneys, they might not work together if you are not careful. So in the kidney will reabsorb things like sodium, potassium, calcium, even blood sugar. Well, not blood sugar, the glucose. It will, if your blood sugar is low, the kidneys will actually have a mechanism where it would know, and it will reabsorb the sugar to balance your blood sugar. The kidneys will also have some hormones that will balance your blood pressure. So really, if you do not have good kidneys, a lot of things will be really affected, included the bones based on the mineral reabsorption. And if your kidneys cannot perform, it will eliminate all the minerals that are needed, and then the bones will suffer. So
Yeah, and then the kidneys are one of the main organs that manages the pH of the blood. This like precise, what's that precise number? Is it like 7.34 to
about
7.45?
anywhere between 6.5 to 7.5 is considered normal. So, but you kind of want it, it's above 7.5 the most, because after that it goes into alkalinity, and you don't really. And then speaking of acidity, there's two parts of that acidity. One, it's one thing in the stomach, you want it very acidic, but in the blood, you don't want it acidic. That's when you're going to get disease. So in the blood, you want to be more alkaline, and that's going to be kind of um, foretold by the urine pH. So you might hear people talk about, oh, measure your urine pH first thing in the morning, and you want that to be alkaline. The reason for that will kind of tell you what the blood is doing. Is the blood too acidic? Is it okay? On the other extreme, in the stomach, you want it to be acidic. You don't want it alkaline. So there's two places. They're both very important, and they're opposites. So
Yeah, again, balance, right? It's like that
mhm.
that balance beam. Okay, good. So then pH strips, testing your urine in the morning is good to make sure that you're not too acidic.
Yeah, it's a good indication. And interestingly, if you don't have enough magnesium, you will be more acidic. If you load up on magnesium and choline and things like that, you will increase the acidity, the alkalinity in the urine, and that's good. So, well, in the blood and then in the urine. So,
Okay, yeah, that's great to know. All right. So, can you explain a little bit to us on what it is exactly you do? And I love the name of your program. That is the medication makeover, or it's Medicine Cabinet Makeover. Can you just
Mhm.
describe what it is you help women do when you work with them? I mean, you might work with men too, but I
Yeah,
mostly speak to women.
yeah. Well, so basically, sadly, a lot of people are on a lot of medications. And even if you're just on one, as I just mentioned, you might be just on ibuprofen or aspirin. That doesn't mean they're safe. So, what I do, I help people to look at their medications and figure out if those medications will deplete certain nutrients. And in the very first thing you could do, and that's what I try to do for the clients, is to um, help them know what those deficiencies will be, replenish them, so that way we prevent further deterioration and further um, side effects, or at least the severity of the side effects. And then I take them into, okay, now that we kind of stabilized you with your medications, why don't we look for the root cause of your first symptoms? So if you are on medications because you have hypertension, question is, well, why did you have hypertension? Was it just stress and inability to deal with stress? Or um, could it be that you just didn't eat well enough and you don't have enough magnesium in your system? And by the way, magnesium has the same mechanism of action as a class of antihypertensives called calcium channel blockers. So medications like diltiazem, um, they have the exact same mechanism of action like magnesium. The only difference is that magnesium will not give you all the side effects that diltiazem will. And so when you deplete this calcium channel blocker, you could cause an imbalance into the hypertension. So, well, the blood pressure, and then get hypertension. So it could be that their first symptom was something that's simple, like they just ate horrible food. Consequently, they didn't have access to good nutrients and they developed hypertension. Could it be just the stomach acid? And then on top of that, then they went on medications for that. So, we dig deeper and we look for the root cause, and whatever we think, oh, okay, so the stomach acid, okay, great. But then what's the root cause of that? And then, it's kind of like an onion. You just keep peeling off layers, and eventually you have to figure out the root cause. And when you fix that, a lot of things downstream will be resolved. So that's what I do. The program is like really just 4 sessions, but you really cannot fix anything in 4 sessions. So a lot of my clients will sign up again after we finish the 4 sessions. So I just keep guiding them through figuring out the root cause. And
That's great. I'm not sure if this is the word that I heard from you, but I think it is. Did you use the word deprescribing?
yeah, so the prescribing would mean that you are taking people off medications. Now, as a pharmacist, if I'm licensed in the state where the patient is, um, it would be within my scope of practice to call the physician and say, look, the patient's symptoms are such and such, their labs are such and such, their blood pressure numbers are this and that. Would you consider to either change the dose or even completely take them off the medication? If, like, let's say their blood pressure is super low now and they're on 2 medications, the doctor will say, sure, let's. Now, I'm not licensed in all 50 states, so all I can do is guide the patients, teach them how to take their blood pressure or blood glucose, and keep track of their symptoms, and advise them when those numbers look in such a way that they should probably call the doctor and have a conversation with their doctor. So
Yeah, that's
So
great. You
again,
educate
if
them. Yeah, that's great.
yeah,
You give them the information and then they can have that conversation.
yeah.
I love that.
Mhm.
Okay, can we discuss osteoporosis medications? And the term that you used for me, that you gave to me, was it's dust in the eye. And I had to think for a second, what does that mean? And then you explained. So if you could explain a little bit about the whole process of osteoporosis medications and how they work and really what the outcome eventually becomes.
Yeah. Well, the problem with the osteoporosis medications is that they're given to the patient to um, prevent fractures. That's the goal. The problem is that trials have shown that that goal is really not reached. So, and then in the process, you also get pre-bed side effects and long-term side effects. And so it's kind of like, it's almost like, and I know I keep going back to the hypertension and to the cholesterol medications, which we think that if my cholesterol is a better number, I'm not going to get heart attacks. But the problem is with those medications, just like with the osteoporosis medications, is that that goal is really not reached. So people just feel safer because they're on those meds, but in reality they're not safe. So
Yeah, and then you need to go from one to the other because this one's only a 2 year. This one is, and then are they all pretty similar? Like the anabolic, the ones that are building up bone tissue, the ones that have the parathyroid, or the bisphosphonates, which stop bone breakdown. Is it all pretty similar? The mechanisms? Is it all dust in our eyes? All of them, or some better than others?
um I I don't think I can compare that, but
Okay.
yeah, they they really don't accomplish what they say they do. So, and then the side effects that come with these medications are just not, I mean, why would you expose yourself to things like that? And
Yeah, what are
um
they though? What are the side effects? That's what I was going to ask you.
so
Well, one thing you said when we were talking about this is you said that there's black box warnings on, and it's almost like the writing is on the wall, but we don't see it. And it really honestly is because there's so much fear and you feel so breakable and fragile. And then I noticed that, there's different numbers for a DEXA scan, but people have this word severe, or they'll say, my numbers are really, really bad. So it's the mindset of how you feel about whatever your numbers are that is a part of what goes into the decision to go on medications. So that's one thing I see. And yes, it's kind of a false sense of security, yet it's something. And when you feel fragile and breakable, you're really grasping for straws. And so they go on these medications. I mean, and it's an individual choice. I mean, I'm just so opposed to medicines. Most medications. I am like, let's get to the root cause. Let's find out the why. So it's interesting because you said that there it's on the box. It says what you're going to get, but we don't even see it. We're so blinded because we're so scared of breaking, and we're like, yeah, let me have it. So tell us what some of those side effects are, and they are actually on the box, unless you're getting an injection
they
and you don't get the box.
they're not on the box, they would be on the package insert. Oftentimes you would not get the package insert unless you ask for it, but they might give you like a information, consumer information, first time when they dispense that. But most people usually just throw it away because it's just pages and pages and pages, and they're not gonna read. Um, so let me just give you this. So here I have a couple of medications. One is Evista, and the common side effects are flu-like symptoms, infections, hot flushes, so it will mess with your hormones as well. And it has a black box warning, which that's what I was talking about. It can cause deep vein thrombosis and pulmonary embolism. So you're going to get a coronary heart disease, especially women that are menopausal. And you're um, at risk for strokes.
Okay.
So okay, you got your bones, but even that, as I said,
Well, you've
that's
got your
also not
DEXA scan score increasing. It
right.
doesn't mean you have
So,
stronger bones or better quality bones. It means that the
right,
DEXA scan, which I think
right.
typically it makes the outer part of the bone, which is red on a DEXA scan, stronger, more layers. But what's happening
Mhm.
inside the bone isn't stronger, and that's the part that matters for fracture. So,
Yeah, yeah, they're calling those brittle bones. So yeah, and then on top of that, you have to now deal with the damage that the medication does. So you might have good bones, assuming that that's true, but you're gonna get yourself a stroke. Okay, so that's one thing. And then the other one is Fosamax. It decreases calcium and serum phosphate. You can have all kinds of pains, bone pains and muscle pains.
and the interesting
It's
thing about that is you have to take it in the morning, sitting up in bed, and it causes for a lot of people severe stomach issues because if you have osteoporosis, which is a disease, you have imbalance. And if you have imbalance, quite often the digestion or the gut is going to play a role. And so you're bringing a medication into your gut where you already have an issue with your gut, it's causing burning. But actually, now they've created a new drug. So then they have all these injectable drugs. So they bypass the digestive system. So it's crazy. And that's what I
yeah,
think. I really feel like women should be educated because that's the big thing for me is if you're going to take medications, that's fine, but understand what it is you're taking and
yeah,
understand what are the other options instead of taking medications.
yeah,
So I
and
don't tell people not to take medications.
yeah,
It's an individual choice. I say
for
I'm
sure.
not taking them, but just educate yourself on side effects. And honestly, some of the women I work with, they told me that this woman that I just spoke with, she said, my doctor never told me that this medication she was giving me was going to lead to osteoporosis. And so that's what's happening. Some ladies I work with that have osteoporosis, it's either from cancer and some of the medications that were given for cancer, or there's other medications that can lead to bone loss. So yeah, and you're telling me about these medications, and it's going to maybe block phosphorus and calcium. Well, there's probably almost two more. Those are like two main ingredients of bones.
Hmm.
So
Yes.
what it's so crazy. I just want
Yeah.
people to know. I want women to know what it is they're doing so they can make informed
So
decisions.
so look at this side effects for Fosamax. You get bone and muscle and joint pain, sometimes severe. 10% of those women will probably experience at least one of this. So I don't know. Is it like, so here you are trying to not have bone pain because osteoporosis hurts, and now you're taking a medication that will give you bone and muscle and joint pain. You can also get muscle cramps and joint swelling, osteonecrosis of the jaw, which basically means that the jawbone basically it's all necrotic, it's all infected and it's chewed out. So
Yeah,
I
or
don't know. There.
spontaneous femur fractures, right? That's I
Mhm.
spoke with an orthopedic surgeon once and I asked, how do you know? And he said it's just the way that the break happens, the fracture happens, that it is typically from some of the bisphosphonates.
Yeah. And
Um,
then, and in what you just mentioned, those fractures are actually post-marketing reports. And so here I can just tell you in terms of research, when they bring medications to the market, unless they capture in the design of the clinical trials the potential that will happen, either a nutrient deficiency or a certain symptom, or in this case, these fractures, it will not be captured. So because anything that goes in the package insert, it's based on a question that was asked of a subject in the clinical trial. So unless the patient came every month and it was followed by the doctor and they did the x-rays and they saw the fractures and they would say, oh, it's got to be from this medication, it will not be captured. And so until it goes out there, and now you have thousands and thousands and thousands of patients on the medication, and the doctor is diligent to say, hey, my patient experienced this, let me call it back to the drug company.
Oh, wow.
And
So what is
then
that called? What do you call this? Like
it's
aftermarket?
it's called post-marketing reports. It's really phase 4
Wow.
of clinical trials.
Wow.
So,
Okay. That's crazy. I have two questions about because I'm this whole thing about being, evidence-based, double-blind randomized studies. I'm not so convinced that we need to hang our hat on all the science stuff. So I have two questions about this. One of them is, are most studies done on mice or men?
oh no, so all studies have to be done both on mice and men. So,
Not women though,
so
right? Not there. Most
well,
of them aren't. A
no,
lot of them aren't done on
no,
women.
they'll do it. So, okay, so before they become clinical trials, they're done in mice or whatever other animals they consider that would be a good model. So based on that data, they have to submit that to the FDA, and the FDA has to say, oh, okay, so you've got some safety here. The data looks good. We are allowing you to move into clinical trials. So the moment they're called clinical trials, they are done on people, on humans. And then in clinical trials, you have 4 phases. The very first phase is more about safety, figuring out a dose, things like that. And those studies are very small, anywhere between 20 people to maybe 100 people. Once the results there look good, then they move on into phase 2, and phase 2 is safety and efficacy. But again, the studies are pretty small, like 300 people, around there. And then when the results are good here, but at every point they run them through FDA, and FDA says, sure, you may now move on to the next phase. And then they get to phase 3, and phase 3 usually it's still about safety and efficacy, but now they are having thousands of people, anywhere from 3,000 to 10,000, something like that. And people say, oh, that's pretty good. But if you really think about statistics and your chances of having something, if the study is only done in 3,000 people and you're having a rare side effect, chances are that that rare side effect will be captured in those 3,000 people is pretty minuscule or non-existent, right? So if everything goes well, then they bring the medication to the market. And that's where post-marketing reports come into play, because the doctors can call in and say, hey, I'm putting the patients on this medication and I constantly see the same side effect. I think it's from your medication. And if enough doctors from all over the world are reporting that, then that thing will make its way into the
Wow.
package insert. But if it's only one doctor and nobody else complains about it, they're going to ignore it.
Yeah, that's why we
So,
see movies where some like maverick doctors got together and took something off. In 1999, my daughter was 10 months old and she had, that's when the chickenpox vaccine was coming out and they recommended that she get that. So I gave her the chickenpox vaccine. She was 10 months old. She got shingles. She had shingles up on the back of her legs and on her elbow. She was crying and a lot of pain. And when I read the pamphlet or I read the research, I didn't read that much because it's so overwhelming. They had there was 13,800 in the trial, and there was only 8 people who developed shingles in that trial out of 13,800. And
right.
so you're kind of, it's like depends on what the sample size is and what the risk factors are really. But here's my poor little 10-month-old getting shingles from a vaccine that I gave her. And so I think it was on the newer side. I think they had been doing that vaccine in Japan and they brought it here. Okay, so I have another question. Has there ever been more than one medication studied? Like, has there ever been a study that has 2 medications in it? I've always heard that there's never ever been a study that has more than one medication at a time.
So, in terms of the study drug, there's only one, because if you study 2, then you won't know who's who. if there's a side effect or if it's a good effect. So you don't know which one caused it. Now, that doesn't mean you cannot look at more than two medications, except that the other medication will be your control group. So, for example, in oncology studies, where cancer studies, they will, in fact, it's considered unethical to do a placebo. So um, they cannot control the drug versus placebo because you're letting people die, right? So it's considered unethical. So because of that, they have to give to the control group, they are giving them the medication that's considered the standard of practice. So then the new medication has to be shown that it's at least as good as the standard of practice, which in my experience, that's pretty much the only thing that they achieve, that it's only as good as what's already on the market. The only difference is that the new drug is now $10,000 a dose, where the other one was $20, but they forget to tell you that part. But
it's crazy. You pharmacists honestly are amazing, because really we would be nowhere. Where would we be without you? It's really the pharmacists that are figuring out. I mean, I've had my parents in the hospital, and the even when the doctors come in and they're prescribing different medications, it's really at the level of the pharmacist where they're going to put on the red flags, or look at what's happening. Yeah, you're the one that is figuring out what's going to interact with each other. And then now, and maybe that's what's kind of really been part of what's driving you, is that you're seeing all of these horrible interactions and all of these horrible side effects, and you're realizing what they're causing, what it leads to. And you're like, wow, wait a minute, let's heal you so you don't even need all of these things. And you said a term that people never heal on meds.
Yeah. And that's the reason, because you might fix something, but then you kill 10 others. So and as I mentioned before, like with the magnesium deficiency, and now you're getting more hypertension, and here you are trying to be on an antihypertensive medication, but instead of controlling the blood pressure, let's say on that just one drug, next thing you know, you are maxed out on that dose. The doctor will add the second medication and the third medication. And on average, people are on 3 or 4 medications for hypertension. People are on 3 or 4 medications for diabetes. So, and when I was a hospital pharmacist, I would always wonder, like, why are people on so many meds? And it was very interesting. We would have standing orders. So when they would get admitted, we would have standing orders with, if they have if they have headache, give them Tylenol. If they have some other kind of pain, give them ibuprofen. If they have gas, give them Maalox. If they have diarrhea, give them Maalox. If they have constipation, give them Maalox. If they have, so basically we were anticipating all the side effects. And in order to make a nurse's life easy, and a patient's life indirectly easy, we would have the standing orders. But basically, I have this picture in my head with the pharmacist having like a pill the size of his own body, with basically tons of little pills inside. And we are just giving them, here's this big pill that has medications for all the potential side effects. So, and don't call me during the night, because I'm asleep. And nurse,
Wow.
have fun with your patient. So,
wow. Yeah. So it's really, you just got to a place of, you've got to stop the madness, right?
I always wondered. And at that time, I did not know what I know now. But I always wonder, like, who ends up on so many medications, and why? And how are they swallowing all that, and why? And it was always on my mind. And then the reason I got where I'm at right now is because I got sick, and I went to the doctor, and they told me there's nothing wrong with me, but here's a medication. And I'm like, so why would I take a medication if I'm not sick? And because according to them, I wasn't sick. And so then I was like, okay, thank you very much, but no, thank you. So I went and I started reading, and everything just pointing me back to biochemistry. Everything was like starting to make sense. And for the first time, I started to understand this. Every medication causes a deficiency in some kind of nutrient that's important all the way down to biochemistry. You mess with biochemistry, you're going to have disease. And that's the bottom line. So, is there a time and a place for medication? Absolutely. Um, if you need a heart transplant, you will die if you don't get it. But once you have it, you will have to be on medication for life, and that's not debatable. You have to be on the medication to live. But before we get to that kind of severity, we have a lot of room to prevent, to help. Sometimes we're born with congenital problems, or sometimes yeah, those are not the debatable ones. The debatable ones are when all you eat all day is McDonald's and you have no nutrients in you. So now you're getting hypertension and diabetes and cholesterol and this and that.
Yeah, it's
And you,
the lifestyle diseases, right? I
yeah,
mean, heart
yeah,
disease,
yeah,
cancer, heart disease, diabetes, osteoporosis.
yeah,
There's a lifestyle aspect to all of these.
yeah, yeah. And um, it's sometimes there might be some genetics. People will argue, okay, well, those will be the people that will really benefit from everything we know, like the science, the medications, and this, that, but not everybody should be on medication, and definitely not long term, and definitely without looking for the root cause. And that's where we kind of forget. So,
All right. Well, this has been really informative. So, is there any last minute, anything you want to say or share or to get your wisdom out there? Anything else?
yeah. So, one of my what I hear often from people is, well, it's so much easier to just take a pill versus change my lifestyle. And especially if we talk about don't eat your gluten, don't eat your dairy. As you said, we kind of get this deer in the headlights, and we're like, what are you talking about? How am I going to live without this? And yes, it's hard, but my mentor always says that it's nothing feels as good, or nothing tastes as good as healthy feels. So if you want to be healthy and really enjoy your life, I would say that having M&Ms versus feeling healthy, I'll take healthy versus enjoying M&Ms for 5 minutes and then I'm done. I'm out of them. And then you're going to be sick for months on end. So nothing, absolutely nothing feels as good as healthy feels. Nothing tastes as good as healthy feels. So while I'm not saying it's easy to be gluten free, because I am gluten free, I am dairy free. It's not easy, and I always have to be cautious. But the how it feels to be able to go hiking, to be able to run with my children, nothing will compare. So
It's not worth the M&Ms. It's better
it's
than
not
M&Ms.
worth the M&Ms. No.
Yeah, people always ask me, are you going to tell me I can't eat this? I can't eat that. I can't. I said, no. I said, what I'm going to do is I'm going to tell you what it does to your bones when you eat this and you
Yeah.
eat this and you eat this. So that's where I feel like this education piece is important. And today it was really great because you shared a lot of information about, for my community, some of the big things, which were digestive support. So some of the medications for digestion, but also this aspect of that medications are a band-aid solution. They're not getting to the root causes. And the bio, you said everything comes down to biochemistry. So it's really this biochemical balance. And that's what, when you do lifestyle practice, I'm a yoga therapist and a functional health coach. So I also work with stress management and psychological stress management, because that's a whole other topic. And I do have people I'm speaking to about stress and cortisol and what all that does in your body. So really, it's about finding balance. Everything is about balance. And I love what you're doing. I love this information you're sharing. It's so helpful. Thank you so much. And if people want to find you, how do they find you?
Well, my website is naturopathicpharmacist.com. And I have some blog posts there about medications. I also started a YouTube channel, so there will be links on my website to some videos talking about various medications, medication classes, and how, one of my latest endeavor was to shed light on people being tired, and they think they're tired because they work too hard or who knows what, but in reality might be their medication. And again, going back down to the biochemistry, when the medications affect the biochemistry, you're going to be tired. So
what is your YouTube channel called?
So they can get links through my website, like under the blog. So that they can find it.
Okay, that's great. So hopefully women are going to reach out to you, and especially if they have multiple medications they need managed. If they want to do a medicine cabinet makeover, you're the person to call, the naturopathic pharmacist, Mihaela Gruita. Thank you so much for speaking with us today. You shared so much valuable information, and thank you.
My pleasure, and it's been an honor. Thank you for having me.
Aw, thanks. Thank you so much for listening to Stronger Bones Lifestyle Podcast. Bone loss is not an inevitable part of aging. We don't have to just wait for it to happen. There is so much that you can do, and that is what you will learn each week on the show. Go to my website, debbierobinson.com, if you want more information about what was shared in today's episode. At the bottom of this episode in the show notes, there will be links to whatever was shared. Please subscribe to this podcast. Share this podcast with your friends, your family, or any women that you think may be interested or benefit from the information we're sharing. Please rate the podcast. And if you have any questions you'd like asked or answered, I would love to hear from you. Let's do this, ladies. Let's change the way the world views osteoporosis and slow down, stop, or reverse our bone loss, take charge, and show other ladies what is possible. Thank you so much for joining me.